Good morning, students. In part 2 of Influence of Systemic Disorders and Stress on Periodontium, we're going to see some more hormones and certain other conditions which exert their influence on the periodontium. Now, hyperparathyroidism. Now, hyperparathyroidism is a condition wherein there's an increased secretion of the parathyroid hormones from the parathyroid glands. Now, increase in this parathyroid hormone leads to decrease in mineralization of the skeleton, increase in osteoclastic proliferation of connective tissue, in enlarged bone marrow space, leading to formation of bone cysts and giant cell tumors. This disease is known as osteitis fibrosa cystica or von Recklinghausen's bone disease. Now, orally, this disease manifests itself in the form of increased tooth mobility, which leads to malocclusion. Now, radiographically, we can see an alveolar bone osteoporosis with closely meshed trabeculae. There can be a widening of the periodontal ligament space and absence of lamina dura, which may not be common in all cases, and you can see radiolucent cyst-like spaces. Now, the bone cysts are present, which are filled with fibrous tissue and hemosiderin-laden macrophages with giant cells, which is known as brown tumors. Now, if you see in the picture, now this image closely resembles that of an endodontic condition, and many a times it can be mistaken for an endodontic lesion. So this slide shows the images of hyperparathyroid patients, and in the first picture you can see the palatal view of a brown tumor, while in the second picture you can see a typical ground glass appearance of the alveolar bone. And if you notice around the roots of the teeth, you can see a total absence of lamina dura around all the teeth. Next, we'll discuss about the corticosteroid hormones and we'll see how they affect our periodontium. In humans, systemic corticosteroid hormone does not affect the severity or progression of periodontal diseases. However, in experimental animals, certain changes have been noted in the periodontium. Now, these changes are increase in capillary dilation and engorgement, and this causes an hemorrhage in the perial and the gingival connective tissue. This is a degeneration and reduction in the number of collagen fibers. Osteoporosis of the alveolar bone is also noticed in these animals. So, the exogenous cortisol does not affect the humans and their periodontium. Now, let us look at the effects of endogenous cortisol. Now, endogenous means that which is produced within the body itself. Now, what does it do? Now, increased stress leads to an increase in the circulating cortisol levels, which stimulates the adrenal glands via the HPA axis. Now, the exact mechanism has been described as the hypothalamus releases the corticotropin releasing hormone or the CRH, which stimulates the release of ACTH, that is adrenocorticotropic hormone, from the anterior pituitaries. Now, this in turn results in the production of cortisol by the adrenal cortex. Glucocorticosteroids like cortisol then depress the immunity, including increase in secretion of the IgA and the salivary IgG and the neutrophil functions, all of which may be important in protection against infection by the periodontal pathogens. And this cumulative effect has an adverse effect on the periodontium. Stress and psychosomatic disorders adversely impact periodontal health. Psychosocial stress is considered as an important risk factor for periodontal disease. Stress increases the circulating levels of cortisol, and this has an adverse effect on the periodontium. Now, the best example to explain this would be that of soldiers who were sent for war. Now, during war times, the soldiers would live in trenches and they would be under extreme stress and pressure. Now they develop a typical kind of gingivitis, which is known as acute necrotizing ulcerative gingivitis. And since it was almost all the time associated with soldiers at war and in stress, this condition was also known as trench mouth. Depression and smoking are also marginally significant in patients with aggressive periodontitis. Now this is because patients with depression also tend to develop certain adverse habits like smoking and alcohol consumption, and these habits along with depression has a detrimental effect on the periodontium. Now next is the psychosocial stress, depression, and ability of the individual to cope or not able to cope with the stress. Now all of us have experienced stress at some or the other point of time, but this short-term stress or acute stress or stress of a shorter duration does not prove detrimental to the periodontium. The kind of stress which leads to periodontal destruction is of a chronic type. Now, which situations give a chronic stress to an individual? Life events like loss of a spouse or family member, a failed relationship, and lack of employment and a persistent financial difficulty, all this lead to a chronic stress, and this leads to a increased periodontal destruction. Now there are studies which have proven that individuals with stable lifestyle and minimal negative life events, they are seen to have less periodontal destruction compared to those who have chronic stress. Studies have proven that individuals with high level of financial stress and they do not have enough skills to cope in this situation had twice as much periodontal disease compared with individuals who don't have financial stress. Now these individuals with poor coping abilities also suffered from poor oral hygiene, and they had paraoral habits like clenching, bruxism, and grinding of teeth, and experienced a decreased salivary flow and also a suppressed immune function. Individuals with stress have a compromised immune system. Now the stress causes an alteration in the immune system and it leads to increase in production of cortisol. Now this together brings about an increase in the release of neurotransmitters like epinephrine and norepinephrine, which interact directly with the defense cells like the lymphocytes, neutrophils, monocytes, macrophages, etc. via the receptors, thereby causing an increase in the tissue destruction. An important point to be noted here is that in the absence of microorganisms, stress alone cannot cause periodontal disease. Stress influences the result of periodontal therapy. Depression has a negative impact on the periodontal therapy outcomes. So when you are treating an individual who is undergoing some kind of stress, it's always important to know the psychosocial condition of the patient. Now this helps in assessing the risk of periodontal disease destruction because individuals with stress have a greater amount of periodontal disease severity and progression, and the potential for successful therapy outcomes can also be judged when you are able to successfully diagnose whether the patient is undergoing some kind of a stressful life event or whether the individual has enough coping skills to cope up with the situation. Individuals with psychiatric conditions tend to injure the periodontium on their own. Now they have certain neurotic habits like grinding or clenching of teeth which leads to tooth loss. Other habits like nibbling on foreign objects, nail biting, and excessive use of tobacco, and self-inflicted injuries which lead to gingival recession are often seen in patients with psychiatric problems. Now this is an example of self-inflicted injury where this patient has a constant neurotic habit of either pushing her gingival margin away from the tooth or nail biting. And in the next picture, you can see the injury it has caused to the gingiva and led to gingival recession. We now move on to the hematological disorders and their influence on the periodontium. Now, in your clinics, whenever you encounter an abnormal bleeding from the gingiva or other areas of the oral mucosa, which is difficult to control, you can always suspect that this might be a case of an individual with an underlying hematological disorder. Clinically, when you see the patient at the time of diagnosis, there will be some signs like the presence of petechiae or hemorrhages in the palate or the mucosa of the patient, which may suggest that the patient might have a bleeding disorder. All blood cells play an important role in the maintenance of periodontal health, and any hemorrhage in the oral cavity or the periodontium is suggestive of a blood dyscrasia. Now, the first condition that we are going to discuss is leukemia. Now, this is a condition which is malignant, and it is characterized with diffuse replacement of bone marrow with proliferating leukemic cells. Abnormal numbers of leukemic cells and forms of the WBC are seen in the circulating blood, and there are heavy infiltrates in the liver, spleen, and lymph nodes. Now, this condition brings about changes in the number of red blood cells, white blood cells, and the platelet count. The oral and periodontal manifestations of leukemia includes leukemic infiltration, bleeding, ulceration, and increased tendency for infections. Now, these leukemic cells infiltrate into the gingiva more commonly and less extent into the alveolar bone. A typical enlargement of the gingiva because of infiltration of the leukemic cells occurs, which is known as the leukemic gingival enlargement. Now, this consists of a thickening of the gingival corium and infiltration of the cells, which bring about an enlargement in the gingival size. Decrease in the normal WBC in circulation occurs, which leads to an increased susceptibility to infection. Thrombocytopenia, which ensues, leads to bleeding tendencies, particularly in the gingival sulcus. Clinically, the gingiva appears bluish red and cyanotic, and there is a rounding and tenseness in the gingival margin. Now, this hyperplasia or increase in the size of the gingiva, it occurs because of the infiltration of the cells in the gingival corium. Now, this gives rise to the formation of gingival pockets wherein the microorganisms can get lodged, and the secondary inflammation which produces the enlargement and inflammation of the gingiva. Microscopically, the epithelium appears thin and hyperplastic, and the blood vessels appear distended with diminished keratinization. And there's an intercellular and intracellular edema and degeneration. Now, what happens to the marginal gingiva? In the marginal gingiva, scattered foci of plasma cells and lymphocytes are seen. Now, this also has the degeneration and edema, and the inner aspect of the marginal gingiva appears ulcerated, necrosed, with formation of a pseudomembrane. The periodontal ligament is seen to contain mature and immature leukocytes. The alveolar bone exhibits localized areas of necrosis with thrombosis of the blood vessels and an intense infiltration with the WBCs, and occasionally there could be even RBCs, and there's a replacement of fatty marrow by fibrous tissue. Now, the dermal component of leukemia is known as leukemia cutis, where there is an accumulation of cells in the dermal and the cutaneous and the subcutaneous connective tissue, forming the elevated and flat macules and papules, as you can see in the picture. Bleeding is an important early sign in leukemic patients, Now this bleeding is caused by thrombocytopenia due to the leukemic cells replacing the marrow cells. So in the oral cavity, when you observe, you can see the presence of petechiae and ecchymoses in the oral mucosa as well as the soft palate. Now bleeding could be caused by the condition of leukemia per se, or it may also occur as a side effect of chemotherapeutic agents. Decrease in the granulocyte count leads to more recurrent infections and ulcerations in the mucosa and the gingiva. Now this is characterized by discrete punched out ulcers in the submucosa, which is covered by a firmly attached white slough, and these ulcers occur more in sites of trauma, and recurrent herpetic ulcers can be seen in these patients. Gingiva appears bluish red, sponge-like, friable, and bleeds persistently. In the next part, we will continue with some more hematological disorders and some immune deficiency disorders and their impact on the periodontium.